Are you facing challenges in your health? Then Dr. Suleiman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Suleiman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Suleiman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at Mile 18 Bolifamba, and in Douala, we are located at Entre Pilot. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Suleiman.
Yes, good morning and welcome to Your Health Today with Dr. Solomon, another Saturday. We're going to be discussing something that is very interesting. We have discussed before. I don't know if it's possible, we'll start with the videos so we can see with this case. It's a reminder of other cases that we have discussed before, but it came my way last week, so I'd like to share it with you. We'll start with video number 1.
The surgery, they tell you the pregnancy was where? The ectopic was where?
They said it was on the right tube.
Right tube. Okay,
Yes,
so now upon scanning after a few months, we see a right ovary complex cyst, the one that I have measured there, and it measured 22.54 centimeters. So this is possible a complication there that has taken place. So we have a right ovarian mass, okay, right ovarian mass, and not only that, if I can show you also, there is fluids. This is the ovary here, this is the right ovary, and here there is fluids that is around the ovaries as well, and that could be inflammatory fluids or God knows what kind of fluids, but anyway, this fluid shouldn't be there. And we can also see the uterus is being compromised. The walls of the uterus has been pushed upon. So it's like this mass is invaginating into the uterus, minimizing the uterus size small. This is the uterus here, that's the endometrium in the middle, and it looks absolutely fine, there's no problem. But this mass here is pushing against the uterus. So this mass here will have to be further investigated. Okay, that's it. A little bit cystic. Okay, we have multiple follicles there. So the left ovary is a little bit cystic. So cystic meaning so many spaces, as you can see. So this is the left ovary, and the left ovary is cystic. Now we need to evaluate the tube, but in the presence of such big ovaries like that, it's going to be a little bit difficult. But we can easily evaluate the tube. We have cystic left ovary. Okay, this is the external iliac. The blood is going through. This is my landmark, and this is my ovary, my left ovary right there. Left ovary looks okay, not as the right ovary. That's it. Okay, that's it.
Let me clarify this case. This is an ectopic pregnancy case. The lady came in, she had a surgery, ectopic pregnancy, a couple of months ago or so, and she came with a little bit of pain on that right side. So when we did the ultrasound, we found a mass. So there are a few questions here that we have to ask ourselves. Why did she have an ectopic pregnancy? We discussed that before many times, but I like to remind you. Why would somebody have ectopic pregnancy? Because the normal passage of the sperms, we have a very small sperm, microscopic, that has to go from the vagina, cervical canal, uterus, all those areas, they have contraction like, so they can help the sperm swim all the way to the fallopian tube, from the fallopian tube to the fimbria, where the egg is released from the ovary and fertilization take place. Once fertilization take place, now we have a sperm that is very microscopic and small, fertilizing an egg that's a bit bigger. Now we have a bigger size from a smaller sperm, very small sperm, fertilizing the egg. Now the size is bigger. So that means I need a wider diameter for those two things, the sperm fertilizing the egg. Now the division start to happen, and that egg start to get even bigger in size, because now we have formation, we have multiplication of the cells to form the zygote. So from a very small microscopic sperm that swam all the way from the vagina all the way up to the ovaries, now we have a bigger mass, that's the zygote. So now this bigger mass has to make the trip back from the fimbria, from the ovaries, all the way to the uterus, through the fallopian tube. So if the tube is not big enough, wide enough, the diameter is not big enough, this structure there, this zygote, will get stuck. And once it gets stuck, it will start implantation. It will start growing. And that is, now we have a growing baby in the wrong place. And that's why we call ectopic. Ectopic meaning out of the normal place, which is the uterus. So now we have ectopic pregnancy in the tube, because that diameter of the tube was not large enough to allow the passage of that zygote all the way to the uterus. And this is the mechanism of ectopic pregnancy. Most common place is the tube. So now the pregnancy starts to develop in the tube. The tube gets bigger, 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 to a point where it cannot get bigger anymore. So boom, it ruptures. Once it ruptures, now we have emergency, because when it ruptures, blood vessels get broken and bleeding starts to happen, and you start to accumulate this blood in the pelvis, pain starts, and then the patient rushes to the hospital. Lucky if there is a surgeon on duty, then the operation is performed, and the ectopic pregnancy is removed along with the fallopian tube, most cases, along with the fallopian tube. So here it is, you have lost already one fallopian tube. Does that mean I cannot get pregnant? Yes, you can get pregnant, relying on the other tube, because normally you ovulate 1 month from one ovary, the next month you ovulate from the other ovary. So yeah, the pregnancy will be every 2 months, because we have lost one tube already. Most common cause of ectopic pregnancy, we discussed earlier in other sessions, we said is chlamydia. What is chlamydia? It's a microbe that get transmitted from male to female, females to male, through sex, and sex only. No towelettes, no towels that are used, none of those stories exist when we're transmitting chlamydia from one person to another. Chlamydia is in the vaginal fluids or in the semen of a man. And once you have intercourse, you exchange fluids, here is chlamydia, okay? Chlamydia is an intracellular organism. That means we cannot see it in gram stain. So if we take vaginal smear, don't tell me I did vaginal smear and they found chlamydia. It doesn't work like that. We have to do serology, or we have to do IgA or IgM or IgG. So this is maybe, so chlamydia exists, it's common, it causes infertility. Because of what mechanism? Because of mechanism that is called internal adhesion to the tube. It causes adhesion, meaning is like a spider web inside those fallopian tubes, whereby it blocked them, and there is no treatment. Even surgery we cannot do. We can only do surgery if the adhesion are external, due to external blood that has been clotted outside. But chlamydia causing internal adhesion inside the tubes, there is no treatment. So infertility is imminent in this case. So what is the recommendation? Make sure before you have sex your partner is clean. Meaning do a small chlamydia test before you decide to have a relationship. And if you do have a relationship, limit the relationship to one-on-one or multiple, but they all have to be in the same circle, and they all have to be checked, and they all have to be clean. So with sexually transmitted disease, this is how we prevent sexually transmitted diseases, no matter what. Even hepatitis B is a sexually transmitted disease, right? And there is a lot of hepatitis B. We have spoken about that before in the previous session. We're gonna now change topics, and we're gonna go to the colon. We're gonna discuss the colon. A lot of problems with the colon, and a lot of patients complain about the colon, especially those who are a bit older. What is the most common organ or part in the GI that patients complain about? The colon. What is the colon? It's the large intestine. Large intestine move. They have motility. So that's why we can move the feces. But now you have to be very careful. This motility differs from one patient to another. If we lose the motility, especially in a small baby, that's a totally different disease. We have a rectum that has no ganglion cells that cannot move. So movement rely on neuron cells, rely on nerve cells that's inside the colon. Once we get older, this movement, these neurons get exhausted. So the motility inside the colon becomes less. And when the motility inside that colon that move the feces towards the rectum so you can stool becomes less, you most likely defecate in more frequent times, meaning constipation. So all people usually we see with constipation. Why? Because the motility of that colon has already decreased secondary to aging. Maybe there is other pathological factors that we'll explore. But you have a patient. I had a patient a couple of weeks ago that came to the clinic with left lower abdominal pain, meaning what? In the left side of the abdomen, but lower abdomen, we have pain. The patient have pain always in the left side lower abdomen, always in the same spot. Years after years, the pain is still there. Nobody knows what's going on. Well, I'm going to tell you. The most common cause for a pain in the left lower quadrant or the left lower abdomen is something called diverticulosis. The name might be difficult, but I'll make it simple for you. We have normally the colon wall. It's a wall that has different layers. Sometimes we have bouching, we have ballooning of this wall. The wall at some point becomes weak. When the wall becomes weak, it bouches out. It make a bouch. So we have the wall going straight, and then at some weak point, it bouches out, and it makes like something like a sac within the wall. So now it's a weak wall that form a bouch. And now what's in the colon? The material in the colon is the feces. So now we have accumulation of feces in that bouch. According to the size of the bouch, according to the size of this balloon, we will have complication. Any balloon, eventually it will get bigger and bigger and bigger. And what is the outcome once a balloon gets too big? It bursts, it ruptures. That is the same thing with diverticulosis. When we have diverticulum, meaning a balloon inside the colon, and especially the most common place will be the left side, left abdominal pain. Those patients, especially a bit older patient, they always complain of the left lower abdominal pain. That is diverticulosis, diverticulitis. We're going to explain the difference between the two. But again, let me not get you confused. We have bouching of that wall of the colon. That bouch can accumulate, feces can accumulate inside. Since the wall is very thick, we have a chance that we rupture some of the vessels. So the patients will see blood in the stools. So we have now left side pain, left lower abdominal pain, and we have a small blood in the stools. That can only be one thing, which is diverticulosis. Blood in the stools with left lower abdominal pain. Most likely it is diverticulosis. So we do not go any further. Now, if the feces accumulate and feces have bacteria, and now we have a wound, so that means we are prone to infection at that site. So that means we have now a case called diverticulitis, meaning we have the balloon that has been injuring a blood vessel. We have accumulation of feces with bacteria. Now we have an infection. How would the patient come? The patient will show fever. So you will have a little bit of fever, a little bit of blood in the stools, and pain in the left lower quadrant. Very much similar to appendicitis, but appendicitis happen where? On the right side. This happen where? In the left side. So if you have left lower quadrant pain, you see a little bit of blood in the stools, and you run a little bit of fever, we know we have a condition called diverticulosis complicated with diverticulitis. Forget about the names. We have a bouch, we have a balloon in the colon that has a bit of complication. Well, number one, bleeding. Number two, possible infection. So now the patient will run exactly the same scenario like appendicitis, So what is the situation here? Well, you cannot go to somebody and tell them, do me an endoscopy, a colonoscopy, whereby I put a colonoscopy there. And the colonoscopy, what we do with the colonoscopy, we put air, we inflate air. So if we have a balloon inside the colon, and then we add air to the colon, what's going to happen to the balloon? It's going to rupture. So that is a problem. So you cannot be doing colonoscopy for a patient suspected with diverticulosis, diverticulitis, because you're going to rupture the balloon, and then we have perforation, and that's a big problem now. So you came with a small problem, we send you home with a much bigger problem. So we do not do colonoscopy for such patient. So what is the recommendation? If we have this case, then we do CT scan, much safer, and we will see the diverticulum or diverticulosis or diverticulitis. We can easily see it with a CT scan. If the patient has the fever and complicated to diverticulitis, then we add a little bit of antibiotics, and the patient goes home and the situation will be resolved. So careful diagnosis and careful approach to a patient with diverticulum, diverticulosis, diverticulitis is essential for the safety of the patient. Number one, we cannot do colonoscopy if the patient proven to have diverticulitis, because the wall is already thin and we can rupture. Best thing to do, CT scan. And after the CT scan we see is safe, we can do a colonoscopy to determine if we want to do something about it. But normally it resolve with a little bit of care.